Our webinar today will discuss living with seizures. My name is Joanne Demas. I'm a Senior Program Manager here at the American Brain Tumor Association, and I am delighted to introduce our speaker today, Kathy Lepica. Ms. Lepica has been an advanced practice nurse at the Cleveland Clinic Brain Tumor Center and has maintained the Brain Tumor Support Group there since 1991. She has been working in neuroscience nursing for 40 years. She recently was a speaker at our Patient and Family Conference this past July. Thank you so much for joining us, Ms. Lepica. You may now begin your presentation.
Welcome, everyone. I have decided that what I'd really like to speak with you about today is going to be living with seizures. And rather than talking about all the different kinds of seizures, we're going to talk about, how you can just manage living with seizures. And we're going to talk first about seizures and brain tumors because the two combined have some unique things that we'll talk about quickly. And that is 10 to 40% of patients with brain tumors will actually present with a seizure as their very first symptom. Now, that's a good thing because it helps us find the tumor quicker. And then up to about 60% of brain tumor patients will have a seizure at some point during their illness. Seizures are devastating to patients and families, and unfortunately, seizures are treated with anticonvulsant medications. And we all know how much patients like to take medications. But overall, seizures can affect your quality of life. Every seizure can cause setbacks and loss of function, depression, anxiety about when the next one's going to happen. And it obviously affects your activities of daily living. And for some people, driving, the ability to maintain your employment, some recreational activities. And so what happens is people become very socially isolated and lose their independence. And then on top of all of this, not only are you dealing with the seizures, but you're also dealing with the tumor. The seizure frequency, which surprises a lot of people, is actually inversely related, which I'll explain, to the degree of malignancy, which means the patients with very low-grade tumors, like patients with things like BNETs and gangliogliomas and oligodendrogliomas, actually have more likely to have seizures. Up to 80% of those patients will have seizures, whereas the patients with the higher grade tumors, only about 40 to 50% of them will have seizures. Now, what causes seizures or can cause you to have more seizures or more likely to have a seizure? Not getting enough sleep, skipping meals, missing doses of your medication, alcohol, and that's because it interferes with the absorption of the seizure medication. It doesn't mean that you can't ever have alcohol, and it's very different with the different medications, so it's best to have that conversation with your physician. Overexerting yourself, stress, even good stress, not at all uncommon for patients to have a very lots of good stress like a wedding or a birth of a baby or a party, and then they're fine for the event, and then after it's all over, they actually might have a seizure. Illness, anytime you get sick, you're more likely to have a seizure. And of course, any other medications you may be taking, including over-the-counter medications, including antacids, may interfere with your seizure medications and cause you to have a seizure. Seizure precautions is something we talk to patients about, and they depend on the type of seizure that you have. The big one are the driving restrictions. And again, not everybody with seizures is unable to drive. It depends on what type of seizure you've had. And it does vary by state. In my state, Ohio, it is up to the physician to make the decision. In other states, it's very well spelled out legally exactly how long it will be before you're allowed to drive. And I have to mention that this includes motorcycles because one of my patients who was on a driving restriction came into a visit and was telling me how great he felt because he got out on his motorcycle for the weekend. And I had to break it to him that, unfortunately, when we talk driving restrictions, that includes motorcycles. Now, as far as bicycles, again, that's something to discuss with your physician. Doesn't fall under the driving restrictions, but may fall under the next category, which is avoiding dangerous activities. And especially if alone, and we talk to patients about things like climbing up on ladders or getting up at heights, swimming or bathing alone, and operating dangerous equipment. And again, these are conversations you really have to have with your physician. The next thing that patients want to know is, and families want to know, is when should I call the office? I think the best bet is that you should notify your healthcare team of any seizure that you have. Now, if your normal is to have 3 seizures a day, you don't need to call me 3 times a day. But again, the best bet early on, especially until we get a feel for your seizures, is that you let us know whenever you have a seizure. Next is that it's the first ever seizure that you have. For some of you, you may not have a seizure at the beginning, but it may occur at some other point in time. So if you have a brand new seizure, we need to know. If there's a change in your regular seizures, or if your seizures start coming more frequently. And the other thing that especially families want to know is, when do I go to the emergency room? Normally, if the seizure does not stop in a reasonable amount of time, if the patient becomes totally unconscious or unaware and cannot be aroused, if the patient has some breathing problems, or if a second seizure occurs pretty quickly after the first. And then, of course, the next question is, what do I do when someone's having a seizure? Well, you want to try to prevent any injury to the patient, so that means kind of getting the area comfortable, moving things out of the way, propping their head, laying them on their side so they can breathe. Someone should stay with the patient during the seizure. And of course, for us, it's very helpful if you can be making some observations and reporting those to us exactly. How did it start? How long did it last? Now, realize that it feels like an eternity, but anything that you can tell us about what happened during that time will be helpful. And of course, after the seizure is over, the patient usually requires some emotional support. They are pretty affected by that. Also, you want to get yourself an ABTA sticker. ABTA has free stickers that peel off and can be attached to refrigerators and cabinets and things like that that talks about what to do in the event of a seizure. And a lot of my patients will get those for their workplace because everybody at work is like, what do I do if you have a seizure? So ABTA has free seizure first aid stickers that you can get from them. The other thing that I recommend for patients is that they get some sort of portable pill container. We all think that we know how our day is going to go, but I don't know how many times patients had some event interrupt their day and did not have their pills with them and missed the dose, and even in the worst case scenario had a seizure. And so there's some a variety of pill containers out there, some that would just attach to a keychain. But I've seen some really nice things, too, with bracelets with little containers in them that look like normal bracelets, and for men, like kind of look like a watch or are a watch, but has a little compartment for to put your pills in. Another thing is that I always like patients to track their seizures. You really start to see patterns, and maybe that will help us decide how we can prevent some of your seizures. And so I encourage patients to keep a seizure diary, and you certainly can do that on a paper calendar. But all of us now have our phones, and so there's apps for that, of course. Some of the ones that I found out there, which were all free, is Seizure Log, My Epilepsy Diary, Seizure Diary. The Cleveland Clinic has a My Epilepsy one out there. An exceptional website is the epilepsy.com site, and they have an online seizure diary you can tap into. And the other thing that I suggest patients do, if possible, is to try to record their seizures for us on their phone, because a picture is worth 1,000 words. and you can sit there and try to describe your seizure for me, but to actually see a video is quite impressive and helpful for us. So next we're going to talk a little bit about how do we choose the seizure medication that we put you on. And I took this little picture because I think Alice in Wonderland, you take one pill to make you tall and one pill to make you small. But, you know, ideally we'd like to get by with just one drug, have you have no seizures and no side effects. But that's the ideal. And sometimes that's not possible in the real world, but we do our best. And you have to understand that 60% of patients will fail their first medication, not uncommon, because it's either because it doesn't control their seizures or the side effects are unacceptable. So sometimes the first thing we try doesn't always work. We always like to get by with one drug, and you'll hear me say monotherapy, but that's what it means. Monotherapy means using only one drug. And the other thing that you have to realize is that there is a 72% chance that you will have a seizure if you go off your medications after being seizure-free for a while. And this is why when you ask your doctor, you know, geez, you know, I've not had a seizure for 3 years. Do you think I can go off my medication? Most physicians are quite hesitant to do that because the chances are high, 72%, that if we take you off that medication, you can have a seizure. And the trouble is we have no useful testing that can tell us which patients are likely to have a seizure. So, you know, we could take you off your medications, you may have a seizure, and then you're back to square one on all of your restrictions. Some of the issues that we deal with, one is generic. And, you know, there's always that question that they're less effective and they have more side effects, and that varies with the drug. It can be more of an issue with the enzyme inducers, which, you know, we will talk about that in a little bit here. But we always have to consider cost and insurance coverage when we're picking a medication for patients. And so unfortunately, in the day and age that we're dealing with now, we often have to work with the generics, and that's what we do. We try to make them work. And so many of the companies do have patient assistance programs and copay cards that we try to tap into if we need to. So we're going to talk about some of the medication issues before we actually talk about the drugs. And the one I just spoke about is the enzyme inducers, and that are drugs that go through the liver and have more likely to interact with other drugs. And they also require some blood level monitoring. The other thing we're going to talk about is this trying to prevent seizures in patients that have never had a seizure. And we sometimes call it prophylaxis, but trying to prevent seizures in someone who has never had a seizure. And then, of course, we're going to talk about the side effects of some of these drugs and drug interactions. So when we're choosing an anticonvulsant with brain tumor patients, there's also often an urgency, so that a seizure happens and you want to stop it, and so you need something that can be given IV and it's going to act very quickly. And so there are very few drugs to pick from at the beginning. Things are starting to change, and we're now having a few more options. But we know any medication can have side effects. So here you go, tumor, take sharp cartilage, get rid of the tumor, but you have a new side effect. And some of the common side effects, I'm going to read this little panel here, this little cartoon. It says, I think we should step down on your prescription, Mr. Adams. We're getting a few side effects. But the most common side effects of a lot of the seizure medications is rash that can be quite severe, fatigue, and mental impairment. And this says if it doesn't itch, don't worry about it, but we know that's not true. But the skin reactions are quite concerning. The big drugs that will cause skin reactions are Dilantin, Tegretol, Lamictal, and Zonegran. About 25% chance that you could develop some sort of skin reaction to those drugs. And there's something called cross-reactivity, which means that if you're on Dilantin and you get taken off and you get put on Tegretol, you know, for a rash, that you may also get a rash on Tegretol or on Lamictal. So we usually go to another drug if someone develops a rash on one of those medications. And the rash can be severe. That's why we worry. There's something called Stevens-Johnson syndrome, and it actually is such a severe rash that the skin blisters and acts as a burn almost. And usually we will find out within 30 days if you are likely to have a rash. But the trouble is that rashes are masked by steroids, and many of you, when you are first diagnosed and you have your seizure, are also put on steroids, and so we may not find out that you're allergic to the seizure medication until we take you off the steroids. Also, it will increase response to radiation. So when our patients are going to be radiated, our radiation oncologist really would like to not see them on any of those 4 drugs if at all possible. And again, the reaction will be worse if the immune system is compromised, and that means if you're on chemotherapy or steroids or your blood counts are low, you're more likely to have a more severe reaction. And then the other issue is fatigue, and that's a tough one to fix, but that is a big side effect of a lot of these drugs. There's also a black box warning that got applied to all seizure medications back in December 2008, and the FDA requires us to warn any patient being put on a seizure medication about the risk of suicidal thoughts and behavior. Now, the risk is very, very low, but really patients, when they are put on a seizure medication, should be told that no matter how low the risk is there. And if you ever have any suicidal thoughts, that you need to speak with your physician immediately, because you will need to come off that medication. Again, when we're choosing an anticonvulsant, we're looking for immediate effect. So initially, Dilantin was the go-to drug, great drug, and one of the oldest drugs we have. But it's not a good long-term choice for our patients, and we'll talk about that a little bit later. Fortunately, we've had a couple other medications come out in the last few years that can be given IV, and that is Keppra and Vimpat. And so those are kind of our choices for the immediate stopping the seizure, as well as things like Ativan. But when we're going to add on a drug or change, there's a lot of newer drugs out now that have less side effects, and some of them have what we call secondary benefits, and we like to keep those in mind. And this says there's no known side effects to this medication, but several notable special effects. But we do have some good side effects on some of these drugs that we try to keep in mind. Again, we talked about that the enzyme inducers, and so these are the drugs that are considered enzyme inducers. They go to the liver and more likely to interact with other drugs, and that is phenytoin or Dilantin, carbamazepine, which comes as Tegretol or Carbatrol, phenobarbital, which we rarely use, myosin, primidone, we rarely use, and oxycarbamazepine or Trileptal. Those are the enzyme inducers. And although they're very good drugs, we often try to stay away from them because they will interact with chemo and other medications. Most of the others do very little effect on the liver, and those are gabapentin or Neurontin, pregabalin or Lyrica, lamotrigine or Lamictal, topiramate or Topamax, valproic acid or Depakote, although it does have a little bit of clearance through the liver, and we try to keep that in mind. And then again, in some of the newer, the zonisamide or Zonegran, Tiagabine or Gabatril, Felbamate or Felbatrol, which has very restricted use because of a really severe side effect called aplastic anemia, levetiracetam or Keppra, and lacosamide or Vimpat. And then there's the issue of drug interactions, and it says, Dad, you might want to talk to your doctor about your drug interactions. But basically, seizure medications can interact with almost every other medication, and that are things like steroids, chemotherapy, antidepressants, anti-smoking agents. And actually, the anti-smoking agents are also kind of what we would call seizure provokers. They can make you more likely to have a seizure, so we do kind of try to avoid those in our patients. Antibiotics and anti-lipid or anti-cholesterol medications are others, because those are things going through the liver. Stimulants that we've used for fatigue can be seizure provokers, so we know that. We talk to patients about that when we're going to start something like Ritalin or Preventative. However, our experience has been that most patients who have seizures can go on stimulants safely and not have seizures. Birth control pills, the seizure medications will interact with birth control pills and make them less effective. They can interact with the blood thinning agents that we use for blood clots. And then all those complementary therapies and supplements and over-the-counter medications that by some of the surveys, about 70% of you do not even tell us you are taking, can interfere with your seizure medications. Okay, the issue of preventing seizures. And like we said, about 20 to 40% of brain tumor patients will have a seizure at the time they're diagnosed. That's how we find the tumor. And of the rest of those patients, another 20 or 45 may possibly have a seizure at some point during the illness. And so the question is, well, should we be doing something to prevent that from happening? And again, we always have to think about the side effects. And it's like, I'd like to get this prescription filled. Well, sorry, my friend, can't do that. This drug has so many side effects, you're better off with the disease. And so that's what we're faced with. And so the American Academy of Neurology actually did look at this issue back in 2000 and issued a report. And what they said is that in patients with newly diagnosed brain tumors, that anticonvulsant medications did not prevent seizures if you hadn't had one. And because of that, and because of the side effects, did not feel that what we call preventative anticonvulsants should be used routinely in patients, newly diagnosed patients, unless they've had a seizure. And so what they said is in patients with brain tumors who have not had a seizure, tapering and discontinuing the anticonvulsants after the first week after surgery is appropriate, particularly if patients are medically stable and are having side effects. And so that's what a lot of us kind of will go by at this point. And again, the side effects, never take a pill that has more side effects than you have symptoms. So we're going to talk about the drugs and their good features and their not so good features. And the first one is Dilantin or phenytoin. So the good thing with Dilantin is it's IV and it gets in real quick and even orally, and it get a good dose level immediately, and it can be taken once a day. The cons are that there's many side effects with Dilantin, and that includes fatigue and mental slowing, ataxia, which is balance problems, vision problems, and that includes dizziness, nystagmus. Your eyes can get a little jumpy, and the skin reactions that we already talked about. And then also Dilantin can cause some changes in the gums to the point that we end up taking patients off the medication, and bone loss over time. And these two usually occur when you're on Dilantin for a long period of time. And again, it's an enzyme inducer, so it goes through the liver and has more interactions with other drugs, and it's very difficult to control the blood levels. The next drug is carbamazepine or Tegretol. So again, you know, the side effects are very similar to what I just spoke about with Dilantin, and so is the skin reactions. And again, that cross-reactivity, that if you have a skin reaction on another drug and you get put on Tegretol, you may also have a skin reaction on Tegretol. Tegretol can also affect the blood count. And a form of Tegretol called trileptal can cause the sodium levels to become low, which makes you mentally slow also. And so those have to be watched if you're on that particular drug. Now, the good thing with Tegretol is it's a very good nerve pain medication. So if patients are having nerve pain, it might be a good drug to try. The next one is valproic acid or Depakote. And Depakote has a little liver clearance. Probably the most bothersome side effects with Depakote for patients is it does cause people to gain weight, and it does cause their hair to get thin and patients will get hair loss. It can increase bleeding time and low platelets, and so we will kind of check those tests occasionally. And Depakote will also cause a hand tremor that can be mild to severe, to the point that patients have a hard time writing, and that may cause them to choose to go off the medication. Now, the pros is that it's a very good mood stabilizer. It makes people's moods better, and the psychiatrists use it a lot for that. And it's a very good headache medication. So in patients that are experiencing either problems with their mood or headaches, it might be a good drug. And then there's gabapentin or Neurontin and pre-GABA or Gabalin or Lyrica. Neither one of them are very good to be used alone. They're pretty good as add-on drugs, but by themselves they're not very good at seizure control. They can cause some weight gain and fluid retention. And Lyrica has some prescribing restrictions. It can only be prescribed for 6 months worth at a time, and it can't be e-scripted. There's a few prescribing restrictions with it. But the cons or the pros are that it is, again, they're both very good nerve pain relievers. And so if patients are having nerve pain, sometimes we will add that medication. Lamotrigine or Lamictal, cons is the rash, and it's got what we call a very slow dose escalation, so that we have to wean you or take you up on the drug very slowly over 8 to 10 weeks. So it takes 8 to 10 weeks to get to full dose, which we don't have that luxury when we're trying to stop seizures sometimes. But it makes it a good add-on drug if you have time. And pros are it's a good mood stabilizer also, and so it may help if patients have some mood problems with anxiety or depression. Topiramate or Topamax. Some of the cons is some patients experience a little cognitive impairment on it, leading it to be Dopamax. And this is minor. It's not an Alzheimer's thing, but it's like a forgetfulness that for some patients can be quite bothersome and make them choose to go off the medication. And it just like Lamictal, it has a very slow dose escalation. So again, it will take us 8 to 10 weeks to get to full dose. And then it does have a unique side effect of causing kidney stones. So if patients have a history of kidney stones, it's not a drug we're going to pick. If a patient develops a kidney stone on this drug, likely we will be taking them off the medication. And then on startup, if patients get an uncomfortable tingling, burning, or pins and needles in the fingers and toes, and sometimes the face, and sometimes even the tongue. Like patients will say, oh my gosh, if I drink a soda, my tongue just tingles. It's a really quirky side effect that will usually clear up after a couple weeks, but for some patients it's intolerable and they choose not to stay on the drug. The pros are that it does cause patients to lose weight, so if patients are struggling with weight, sometimes we'll consider this drug. And it's also a very good headache medication. So again, if patients are struggling with headaches, we might go to this medication. The next one is zonamide or Zonegran. And the cons is that if you have a sulfur allergy, you should not take Zonegran. And it also can cause a rash, and it also can cause kidney stones. The pros are it's a very good headache medication. It causes patients to lose weight, and it's once-a-day dosing, so you only have to take it once a day, and sometimes that's attractive for patients who have trouble remembering to take their medication. The next one is Keppra or levetiracetam. Pros is it's a good, what we call monotherapy, single-agent drug that can be used by itself, and it is very often, although interesting, it's not FDA approved as that, but we really don't see much problem with it with the insurance companies. It's a very quick start. Within a day or two, you're up to full dose. It has an IV form if we need to give it IV when patients are unable to take pills. And it has an XR dosing, which can be taken once a day, so will cause some less side effects and less chances of missed doses of medication. Now, the problem with Keppra is that it does, in some patients, cause some psychological effects, primarily some irritability and anger. So it's been doped Keppra by the patients. And it can become quite bothersome. And interestingly, usually it's the family members that complain about it and not the patient. And the things we hear is he has a short fuse. I have to watch everything I say around him. She goes off at just at, short fuse. And again, there's some things we can do. Sometimes we have patients try vitamin B6, 50 milligrams once a day, and that's enough. We can try decreasing the dose if we have that luxury. Patients' seizures are under control, and we think it's safe to try to decrease the dose. Otherwise, we really are usually looking at changing them to another drug. Lacosamide or Vimpat, the pros is it's probably one of the more recent drugs that we are using. It has a unique mechanism of action. It works on activating the sodium channel, so no other seizure medication does that, so it's a good add-on drug because it's working in a little bit different way. It's been pretty well studied, and it's shown to be a positive add-on drug with a lot of other drugs, particularly Keppra. There's been clinical trials done. And it's got a moderate dose escalation, which within 2 weeks we can have you on full dose, although they just got approval for what we call a loading dose. So actually we could, in patients that need to get started immediately, give them a full dose on the very first day, which is what we call a loading dose, and then go to the standard dose. The cons is it was initially approved for partial seizures only and not the generalized seizures, and only as an add-on drug. However, it just now has been approved by the FDA to be used by itself. And so I think that we'll see it being used a bit more. Side effects, these are mostly seen on startup in the first couple weeks until patients get used to the dose. And patients will have a little bit of dizziness, a little bit of imbalance, like feeling faint. Some patients get a visual disturbance, particularly patients that are doing a lot of reading or computer work will complain that they can't get their eyes to focus. Again, these usually will go away after a couple weeks, but for some patients they are unacceptable. And then it can have an effect on the heart rhythm, and so in patients that already have a problem with their heart rhythm might not be the best medication to use. Because it's newer than the other drugs, it is not out in generic, so it can be expensive on some insurance plans or not approved at all. And then it carries the same prescribing restrictions as Lyrica in terms of you can only get 6 months worth at a time, cannot be scripted. More of an issue for the doctor's office, but again. And then we have what I call the new kids on the block. And these are all the new medications that have been rolling out in the last year or two, which is exciting. And usually these are in brain tumor patients used as add-on only because most insurance companies make us show that you have failed all of the usual drugs that we just talked about before they will allow us to go to these medications. Many of them will require prior authorization or not be covered at all, or have very high copays because none of them are out in generic. But you need to know that they're out there, and there are times that we do look into them if nothing else is working. And that's asclarabine acetate, which is Aptiom, azogabine or Potiga, Parapanel, and I'm getting used to these medications and pronouncing them, Vicompa, topiramate XR, which is an XR form of topiramate, and oxycarbazine XR, which is an XR form of trileptal. And so those last two are now an XR form in those drugs that can be taken once a day. Now, Oxtellar XR does have an under the name of that drug in the mobile health library apps for seizure tracking. But you do have to go in under that drug to get to it. Something really important on our end is making sure patients are very educated about a lot of the things that I've talked about so far. And that is when to take your pills, what are the side effects, what are the other interactions. And so I like this slide. It says, Dr. Joe said I have to take one of these pills every day for the rest of my life. Well, that's not unusual, Larry. We all have to take lots of pills every day. Yeah, but he only gave me 30 pills. So sometimes it's just us being very careful about how we explain things to patients when we start them on medications. Just kind of winding down here with a few more little things, and we'll be done, and we'll take questions and answers. So most patients with brain tumors will experience seizure control when the tumor is treated. So radiation, surgery, medication, and chemotherapy with the seizure medication will be able to control the seizures. Now, about 15% of brain tumor patients will continue to have what we call intractable or refractory seizures. And so what are intractable seizures? Well, number one, most patients that have intractable seizures are those patients with the lower grade tumors, and patients that can have long periods of remission where they're functioning pretty well. But then they're having these seizures that are significantly impacting their quality of life, and they're taking multiple medications to control those seizures that are causing significant side effects. And again, what is intractable seizures? Really, they're any seizure not controlled by medication, especially if more than one drug is required, and patients are still experiencing side effects and still having seizures. Again, so in these patients, we try to sometimes think about sending them to the epilepsy seizure specialist for evaluation, either for a medication change to one of the newer drugs that they're much more experienced at using, or to possibly consider something we call seizure surgery. And I'm going to speak very briefly on that because, again, it only affects about 15% of you. But so there is a difference between tumor surgery and seizure surgery. Tumor surgery, we're really needing to get a diagnosis, wanting to remove the tumor to take down all the swelling. And we know that the more tumor we can get out, the better patients will do. So like to try to get 95% or more of the tumor out. And there's an urgency there to do this quickly. If there's any mapping done, it's for what we consider critical functions, which are things like motor movement, movement of the arm or leg, speech, or memory. But they don't necessarily map to find the seizure focus. The target is to get the tumor out safely and as much of the tumor out as possible. And the problem is that sometimes the seizure focus is not always in the tumor or in the portion of the tumor that was removed. So then patients will still continue to have seizures. What makes seizure surgery different? Well, it's often done as a second surgery in brain tumor patients because, like I said, for all those reasons I talked about, there's an urgency with the first surgery. But if we're considering going back in a second time, we might think about mapping for the seizure area. It's a very expensive and time-consuming workup to try to do that, map and find that part of the brain that is causing the seizure. And the goal of the surgery is more to remove that area of the brain that's causing the seizure. And that is the goal. So again, you know, it's something that we try to keep in the back of our mind for the right patient. And I'm going to end up here with, please talk to your healthcare team. Tell us what's important to you. It's going to be different for everyone. Talk to us about your symptoms. Talk to us about the side effects of the drugs that you're taking. Tell us what medications you are taking or are not taking. And we all know that some of you are not necessarily taking your medications like you're supposed to or when you're supposed to, but it would really help us if you'd be open and honest with us about it. And never feel afraid to ask questions. We may not have the answers, but we're happy to try to answer them. And I always like this little one. Snoopy, it's been a bad week for me. What can you do when everything seems hopeless? And Snoopy just gives her a little kiss, and that's good advice. And sometimes we don't have the answers, but we'll try our best to get there. And I think at this point we're ready for any questions and answers if I've left you enough time.
You left us plenty of time, Kathy. Thank you so much. That was wonderful. And we do have a bunch of questions coming in, as well as a bunch that were sent in before time. So we'll start with one that just came in. Someone's asking about wanting to know if this is a side effect or if it's a seizure or if it's tumor growth. Someone is experiencing chills with goosebumps mainly on one side of the body. So how would you know if that's a side effect, a seizure, or a sign of tumor regrowth?
So a lot of times with seizures, the tip-off is it's the same thing every time. And so the more patients will report having an event that is the same thing every time, the more you have to start thinking it's a seizure. Now, with that kind of side effect, the number one question would be if it's only on one side of the body, is it the right side of the body? I'm not meaning the right-handed side of the body, but is it relating to where the tumor is? So if your tumor is on the right and that symptom is occurring on the left, it could be a symptom of the tumor, but if it's sporadic and intermittent, it could very well be a quirky seizure. If it's occurring on the same side as your tumor, it's probably not. You know, and those are the things we have to kind of sort out, and then we'd be kind of more leaning towards it being a side effect of something. Although when something's on one side of the body, it's usually not a drug effect, because drug effects will usually occur on both sides of the body, for the most part. So again, when I tell patients, if you're having an event and it occurs sporadically, and it's kind of very similar every time, you tell me this happens, this happens, this happens. And particularly, most of these seizures will not last much more than 30 seconds to a couple minutes. So it comes and it stops. I'm kind of leaning more towards seizure. I hope that helps.
That's great. Thank you. Next question is wondering if the worsening of seizures is any indication of tumor progression.
And so that's a good question, and that's a question we struggle with all the time. And so I like to reassure patients that a lot of times, just because the seizures act up does not always mean the tumor's acting up. So that they don't panic every time their seizures change. But again, that's the reason for calling us and telling us what's different, and then we can make decisions. So a lot of times patient seizures will act up, and we can never really pinpoint a cause. But it is always concerning when the seizures change or act up, that one of the possibilities is that the tumor is also acting up. Usually how we will approach that is we would probably be on the safe side and do the next MRI sooner and just see what's going on. And then we have that peace of mind if everything looks fine, that we know it's not the tumor, and then let's try to figure out why the seizures are acting up.
Great. Someone has a fairly straightforward question, but I also want to read into it a little further too. They're asking about, that they've been on Keppra for a couple of years and there hasn't been any breakthrough seizures, and the doctor wants to possibly go off of it, which I know you addressed. But how do you address and this patient talks about living alone. How do you address the fear that patient is feeling about living alone, the possibility of having another seizure, and this happening again? That's got to be a concern, right? And
it's a
how do
real
you go about that?
concern. Yeah, and for that reason, like I said, it's usually the opposite. Patients are begging us to take them off the medication, and we are, giving them the litany of all the reasons why they should stay on, that being one of them. We can't predict who of anyone out there that, if we take them off their medication, we can't predict who is going to have a seizure. And as high as 70% of patients, if they go off their medication, may have a seizure. That's a high percentage. And so, it is a concern. Now, especially when people live alone and have seizures, you kind of look at trying to have some safety measures in place. One of the life alerts or something like that, where you actually have something attached to your person that if you have a seizure, you can call, click a button and call someone immediately, and you have the, this blood will come out, or your neighbor will come over, or whatever it is you have arranged. I think that's probably the most safety thing you can have. And the other thing, families do a lot of different things, just having someone checking in with patients at least daily, if not more often. But after that, and then again, if you live alone, it's trying to not do any dangerous activities that will put you at risk if you would have a seizure. But yeah, it's a toughie, and for that reason, most of the time if patients are not having a problem with the medication, we just recommend they stay on it. Even if they are having a problem with the medication, we're happy to chit-chat with them about switching to another medication. There's certainly enough other medications out there. So, we talk about, okay, you don't really like how you feel on this medication. Like, here's a few other drugs that we could switch you to.
Great. That really helps, and that helps me because we do want to address that emotional issue that they're going through as well. Question, do antacids interfere with AEDs?
Yes, in fact, people don't realize that they really can interfere with any medication, and the best thing is that not to take, because the whole way that antacids work is they coat your stomach, okay, to protect your stomach against other things. But for those medications that are being absorbed in the stomach, it's also going to prevent medications from being absorbed properly. Now, some of it will get absorbed, but it may not be the full amount. And so the best thing is to not take an anti-acid within an hour or two either way of your medication. So not like an hour or two before or an hour or two after. I realize that might be near impossible, but you want to keep that taking the antacid as far away from taking the pill as possible so that the pill will get absorbed properly.
Great, thank you. Could you just go over, I know you mentioned it in the very beginning, but we had another question about it. When should a patient go to the hospital, call their doctor with a seizure? Is it their first seizure? Is it the length of the seizure? Just so there's no confusion, because we've had the question posed again.
Sure. So again, if you've never had a seizure before and you have one, or you have what you think is a seizure, you should call. If your normal seizure changes in any way, so like maybe before you just have a little twitching in a finger and now the whole hand is twitching, if it's lasting longer, if, all of a sudden you used to get one a week and you're having 3 a day, if they're coming more often, or you're having a new kind of seizure, which sometimes will happen. Patients have like one kind of seizure and then they start having a totally different kind of seizure. Any of those, I think, requires a call to your physician. Now what happens is that as we know patients and know their seizures, you should always have a conversation with your physician, because not all seizures do you need to go running to the emergency room. And some of them, you can just stay at home and then let your physician know they happen. So I think it's that, like, having that conversation with your physician about, okay, when should I worry and when shouldn't I? When do you want me to call you? When don't? But, mostly it's like if you normally have 3 seizures a day and you're having 3 seizures a day, you don't necessarily need to call me. If they start lasting twice as long or you're having a different kind of seizure, then you probably should. So it is a very tough thing to make a decision about. I always tell patients I'd rather they call than not call. But again, I think that's something that you should have that conversation with your physician.
Great. Thanks for clarifying that one. Question about a refractory seizure disorder. Wondering if it's common to experience periods of eye movements, facial spasms, and difficulty saying words.
Yeah, all of those. I mean, so again, the refractory seizures are seizures that we are having difficulty managing. And so, patients may be on 2 or more medications at full doses and still having seizures. I mean, that's what we consider intractable or refractory seizures. Yes, I mean, a lot of patients will just have facial twitching, eye blinking. Again, that you can also have those symptoms and be something totally different. Like there's something called hemifacial spasm where patients get twitching of their face or eye blinking that aren't seizures. So you need to kind of talk to again, I may keep saying talk to your doctor, but, because we're the ones who can sort that out for you. Is it a seizure? Isn't it a seizure? What do we need to do about it? Because it is very difficult with some of these seizures to decide if they really are seizures or not. It's not that easy.
Okay. That's a hard one. Is there any way to tell if fatigue or mood problems or cognitive problems can, cause the focal seizures? Someone's just asking that they want to get their life back and they want to get off Keppra. Is there a way to improve, some of the different areas to get off Keppra?
So, yeah, there's a lot to this. Yeah, there's a lot here. Number one, I mean, a lot of times with our patients, it's extremely difficult to decide how much of the mood and memory stuff and even speech stuff is being caused by the seizure medication, by the tumor, by some of the other medications. And so sometimes it's not that easy. But number one, if a patient comes to me and tells me that, they really are not happy on Keppra, the side effects are unacceptable, we're going to sit down and talk about, okay, I don't know that I'm going to be comfortable taking you off. Depends on what the seizure story was and the tumor story is. But I'm happy to talk to you about some of the other medications that we can switch you to and how we would do that. So that's kind of usually the first choice, is not to go off the drug, but to switch to another drug. Now, the other thing that we do, and I realize that not all facilities have this option, we have a neuropsychologist on our staff. We go to him. We send patients for a neuropsychological testing, which is about a half-a-day testing where they are put through a battery of tests. And then our neuropsychologist interprets those tests and then helps us out a little bit. How much of this does he think is actually from where the tumor itself is located? How much of it does he think is the medication? And if so, which medication might be the culprit? And so we do recommend patients consider doing that type of evaluation. Patients find it a little frustrating because, again, it is a battery of tests. And what I hear from patients a lot of times is that I feel stupid. I couldn't do that. It made me feel awful. But it really does help us try to sort out. And then a lot of times, too, when we do that testing, it also will tell us, like, will this patient benefit possibly from some kind of therapy. And so if, maybe they would could do some cognitive therapy, the kind of memory stuff that they're having, and might be a little bit fixable, and we could send them to a cognitive therapist and do some therapy, not so much to fix it, but to teach them how to live with it and how to compensate for it is a lot of what we do. So I think that is a really important thing that sometimes we forget about. And the other time that we will send patients for that kind of testing is when patients are trying to decide whether or not they can return to their back to their employment, their work situation. Not really sure that they can go back and do the job they used to do. Doing this testing and having the feedback from our neuropsychologist is very helpful in deciding if patients will be able to return to work or if there will need to be modifications made in their job.
Thank you, Kathy. That was a perfect last question. It kind of rounds it all out, and I think that neuropsychology plays an important role in all brain tumors, but especially in this area when it affects your whole life, and people need to know that there is this discipline out there that is important as doctors and nurses, and social workers. So thank you for mentioning neuropsychologists and the testing and how they can help out. So we're almost at the top of the hour, so that's all the time we have for questions. I did want to mention one more thing, that if you didn't catch that, Kathy put a great plug out for ABTA, that we do have a seizure cling that you're more than welcome to email ABTA or call us on our care line, and I'll give you those numbers. It's a cling that will stick to any surface that talks about things you can do during a seizure. We'll send them out to you free of charge, and you can put them in areas for your family members, your coworkers, to know what to do in case of a seizure. So thank you once again, Kathy. We really appreciate it. If you want information about any of our tumor or treatment information or our seizure information, you can email us at abtacares at abta.org or call us on our care line at 800-886-2282. And we're just going to pause for a moment right there to stop the recording, and then we'll come back for some brief announcements about further webinars. 1 second.